So what I'm going to do today is to, first of all, just start talking a little bit about myself, to give a bit of a context, I guess, for some of the things that I'm going to talk about in relation to those three areas, polio, typhoon and Ebola. So I thought I'd start when I was in medical school. In fourth year, when we're around 21 years of age, our colleagues all write something about each other and it gets published in the bulletin. And I was described as a pint-sized adventurer whose ambition was to do everything. And I think that kind of in some ways explains the way that my career trajectory hasn't been the traditional one of an academic, but rather I've moved around in quite a lot of things, and I'm passionate about a lot of things, and I'm sure that'll come across. In fifth year medicine, I went to Papua New Guinea and did a student elective, and I was really interested in Papua New Guinea because of the many diverse cultures and so on that are there. But instead of visiting where the diverse cultures were, I ended up in Kimby and West New Britain because the scuba diving there was really, really good. So I got to enjoy the scuba diving, but also to get a bit of an experience firsthand of what primary healthcare and indeed any healthcare is in such a poor country. And my conclusion from that was that really what Papua New Guinea and I assumed other countries needed, they didn't need Western doctors coming over to do clinical medicine. What they needed was local people, perhaps not as highly trained as we were, but with the local knowledge and the language, etc. And also the systems that were in place, that need to be in place to ensure that the health system works well. So I put aside international health for a while because I didn't associate health systems with medicine at that stage, or even indeed prevention. And while I was finishing my med school and when I was doing my PhD, which incidentally was in viral immunology, it was nothing to do with public health, I became very active in the environmental movement on a number of issues. And through that, I think, grew a bit of a sense of consciousness about the broader issues affecting us all and social justice issues as well. I went to Washington, DC to do my postdoc. I was there for 3 years, and after about a year, I decided to move to a neighbourhood which was, some people might have described loosely as a ghetto. You know, it was where a lot of poor people live, predominantly black, but a fair number of Latinos also. And I found that what was going on in the street was a lot more interesting than what was going on in the lab. You know, I knew most of the drug dealers around the neighbourhood and their mothers, and I was quite engaged in a lot of activities around, I guess, empowerment and trying to help get people off the street and so on, and just really starting that journey of understanding what some of the drivers are of behaviour, why people do what they do, and also some of their vulnerabilities related to such things as racism and poverty and so on. So I decided that that was far more interesting than laboratory work, and so I wanted to do public health. And a colleague of mine back in Australia got in touch with me and told me about this wonderful program which was called the Master of Applied Epidemiology at Australian National University. And in this program you got to spend most of your time in that stage just in a health department, but over time that changed and you could do it elsewhere. But, you know, we did some study in Canberra as well, and I got to be based at Queensland Health and just fortuitously happened to be there when the first human cases of Hendra virus were identified, and Queensland Health at that time was pretty under-resourced, and so I basically ended up leading the investigation of the human side, and from that really again started to appreciate some of the environmental factors that influence health. And that was a pretty scary time, but very scary because we didn't really know how extensive this was going to be. We knew it was a pretty severe disease, but also a great learning experience and opportunity to work with veterinarians and wildlife people and across government in a fairly junior role. I also helped start the first hepatitis C support group in Queensland, and through that again my interest in marginalised groups, in this case mostly current and former injecting drug users, kind of added to that education. I briefly was an academic at University of Queensland. I worked in the Philippines a few times, mainly supervising students but also doing some of the preliminary work towards a pneumococcal vaccine trial. But then I moved tack and ended up as Director of Communicable Diseases at Queensland Health. So that was my first kind of management role, and again a huge learning experience, but that included a whole range of things from disease surveillance to STIs, HIV control, immunisation and the like. So again there a whole lot of systems stuff as well as a whole lot of work that required engaging affected communities and so on. And then I decided to take a break from that, and I went to Nepal for 3 months to do some polio eradication work. And following on from that, was asked to go back to India for a year. So this is now in 2000, 2001, and I'll be talking a little bit about that time later on. I came back and then continued work for Queensland Health, and ultimately was promoted to become Executive Director of Population Health Queensland, which then covered the full gamut of public health. And again, my education then broadened to look at the whole determinants of health and how you might actually affect them. And I was a bit frustrated at that time because through that time I also became much more engaged in climate change. And while I was working for Queensland Health in that job, I did as much as I could, but I felt frustrated, the tension between the amount of time I had to spend working versus the small amount of time I had to do much else. And so I applied for and was successful in gaining the position of CEO of Greenpeace Australia Pacific. And that was a whole different experience and a great one. It's a great organisation. But I left there to come to Perth to be with my partner, so it's just amazing how love will drag you away from even the best jobs. And here I am teaching infectious diseases epidemiology and about the public health response to climate change for the Master of Public Health program. And also I've had the great privilege of being able to now do 2 deployments via the World Health Organization, first of all to the Philippines post Typhoon Haiyan, and then most recently to Liberia for response to the Ebola epidemic, and that's largely what I'm going to be talking about today. So I start chronologically, so I thought I'd start with polio. And many of you will not have ever been aware of anybody who's had polio because it is a vaccine preventable disease, and it is mainly spread by faecal-oral route, but the vaccination campaigns have been very successful in countries such as ours because we've got the systems in place to vaccinate people young, but also because we've got the sanitation and the housing and so on, that you actually need fewer proportion of the people in the community to be immune to prevent polio spread than you would in a circumstance where people live in close-knit surroundings with very little sanitation. So my first sojourn in polio eradication was in Nepal-Ganj in Nepal, where the year before I was there, there'd been 4 polio cases, the only polio cases that had been in Nepal in that time period. And then following on to that, I was, in that time period, there were about 300 cases a year in India, all in Uttar Pradesh and Bihar. And as I'll show you on the map in just a second, Nepal-Ganj is right on the border with Uttar Pradesh, and there's no coincidence that that is where those cases were. So a bit about Nepal. There's been quite a lot about Nepal, obviously, in recent times in relation to the 2 disastrous earthquakes. But Nepal is actually one of the poorest countries in Asia. Their life expectancy at birth isn't too bad by African standards, but if you look at by Australian standards, it's pretty poor, 68. And their GDP places them at around 207 ranking of 228 countries, so pretty low, that's their per capita. And when we think about Nepal, we often think about mountains, and many of us have spent time enjoying those mountains and the wonderful people who live there. But I was based in Nepal-Ganj, which is that little place that I've circled in red there, which is a flat, hot, dusty place right on the border with India. And every morning when I was there for exercise, I'd go for a walk, and my interpreter and I, we would walk to the border until we weren't allowed to go any further and come back. It was that close. to the border with India, and that was why there was this issue still with polio, because of the fact that it was close to where there was ongoing polio transmission in India. Just a shot of Nepal Ganj. For all intents and purposes, if you saw a photo like that, you'd be thinking that you were looking at an Indian city, not necessarily a Nepal one. My role in Nepal was a fairly basic one. I was part of what they call the STOP program, which was called Stop the Transmission of Polio. That was sponsored by the CDC in the USA, but working with World Health Organization. And we were basically volunteers coming from a whole range of different backgrounds, working with the WHO and local staff. And so when I got to Nepal Ganj, we decided that the thing that would be the most useful was to look at routine immunisation coverage in there and the surrounding areas. And not surprisingly, we found that there was pretty poor coverage amongst the most marginalised groups, and that's a theme that will continue throughout my presentation. So Nepal is largely a Hindu country, even though we tend to think of it as Buddhist often because of the mountainous areas people are Buddhist. But it's predominantly a Hindu country, but there is a significant Muslim population in parts. And so it was the Muslim people who were marginalised, often the poorest, living in the most difficult conditions, and to some extent separated from the rest of the community, where the immunisation coverage was lowest. And it's a bit of a no-brainer, isn't it, that would be why that would be the case. But as I'll talk about in a minute, that was not just the case only in Nepal, it was also the case in India as well. So then, while I was in Nepal, I was asked whether or not I would like to come back for a year and work for the WHO in India. And at that stage, there was polio only in 2 states. There was Uttar Pradesh and Bihar. And this is a more recent map. So when I was there, Uttar Pradesh included the bit up the side there to the left of Nepal there, Uttaranchal, and Bihar was both Bihar and Jharkhand. It's not all that relevant, except that these states being larger meant that they had a lot of population. So Uttar Pradesh had 180 million people when I was living there. I think I looked the other night and it's almost 200 million people now, just in that small amount of space. And those two states together were considered by the rest of India as being the backward states for India. So they had the lowest literacy rates, high birth rates, very high population densities, and the sorts of things that you might then expect to see, diseases that have been able to be eliminated elsewhere continuing, and that was certainly the case. The only 2 states where there was polio. So when you think about that population density, 828 people per square kilometre, and we think about what we enjoy here, and then we think about the fact that most people, and certainly then, and I think it continued, lived in a kind of rural setting where they were reliant, basically a subsistence lifestyle, relying on what they could grow, for their whole food and livelihoods. Then you can imagine, if people are most of the area was fields, but where people lived, even though they might be considered villages, were actually very, very densely populated. And this kind of dense population contributes to the transmission of diseases such as polio. So both of those states also had a high Muslim population and a lot of corruption as well, which kind of just added to the challenges when you're trying to have a functional health system. So I think I mentioned that at that stage there were around 200 cases per year, and even amongst those 2 states where there was polio transmission, it wasn't scattered right throughout all those 2 states, it was localised to certain districts, and in Uttar Pradesh case predominantly in the west where there was the highest Muslim populations and also some of the densest population. So how do you eradicate polio? Well, basically you have to do a combination of things. You have to do the surveillance so that you know where the cases are, and the surveillance has to be really, really good. And in fact, there are ways that you can measure how well your surveillance is going with polio, which is unique really to polio that you can do that. And India at that time, and even in those two states, had pretty good surveillance, so they were fairly comfortable that they were picking up all the cases. But at that stage, they're unable to make sure to get people immunised sufficiently. Even with 5 national, at this stage sub-national, so restricted to those two states, immunisation days every year, and that includes house to house, going house to house, finding every child. So a huge, immense effort. Prior to going to India to do this work, one of the things that fascinated me and made me really want to go there was the concept of that scale. So on one of those national immunisation days, just in Uttar Pradesh alone, 25 million children were vaccinated. Quite extraordinary, and that's just children under 5. And then also we need to boost the routine immunisation and do immunisation of people around where cases have occurred. So the way in which WHO is set up, WHO normally isn't very operational. It tends to be predominantly advice and working closely with government. But polio was really the first time I think that WHO got more operational. And they had, when I was there, 1 surveillance medical officer for each district, so that was around 80 of them. I'm told by people now they have 3 to 4 per district, so even more people on the ground. But these people were the real nuts and bolts, the people paying attention to detail, making sure everything worked and so on, while the actual activities were done by the government but funded through WHO by international efforts, including Rotary International being very active in polio. So what were some of the things that we learned from the time there? Well, again, that where the cases were occurring and where the challenges were with these immunisation days, where people weren't getting vaccinated even though it's relatively easy and you could go house to house, were in the places where the people were marginalised. And there was a particular mistrust, particularly amongst the Muslim population, of the polio vaccine, and a belief that the vaccine was going to make their kids sterile. And that related, unfortunately, to the history of forced sterilisations during Indira Gandhi's era, which did actually target marginalised groups, such as Muslims and so on, in particular. So it's understandable that they had that, but of course this wasn't what this program was about, but it was something that had to be overcome. So there was a lot of discussion around how we can do better social mobilisation and better engagement of religious and other leaders in those communities to try and help promote the program. The corruption in the health system was also a major barrier. It meant that quite a lot of the resources that were meant to go to immunisation on the ground got siphoned off. And we had a couple of energetic surveillance medical officers who decided that they wanted to take it on, and one of them told me how he'd been invited to dinner by the district medical officers at house, and then at an appropriate time in the dinner he pulled out a gun and just pointed out to him that he better just not go there. And that was in the context of just before I'd arrived, the Director General of Health for Uttar Pradesh had been shot, and he was very active against corruption. So knowing that sort of stuff, you can't take on the corruption front on, you just have to figure out how you can work around it. And that's ultimately what happened. Well, one of the things that really struck me when I was there was that this extraordinarily high birth rate, as well as minimal sanitation. So you'd walk around and there'd be babies shitting in the streets, and if you wanted to go to the toilet, there was nowhere you could go. There were very few surveillance medical officers who were women, but one of them was based in one of the districts. And when I visited her, she told me how she would not drink all day so that she didn't have to go to the toilet because there was nowhere that she felt comfortable to go. So that was somebody just visiting these places, but imagine if you lived there. So what that means is that there's plenty of opportunities for faecal-oral transmission of viruses. So, and the very high birth rate. So once I was visiting this village where I'm sure they probably hadn't had a white person visit before. It was a village of about 10,000 people and very narrow. Because you have to save all the land for farming, it meant that the passage between the houses and so on was this very narrow passageway. So I'm walking with my interpreter down this narrow passageway, and the kids see me and they think, oh, this is fun. So next thing you know, I felt like the Pied Piper of Hamelin. There were just kids everywhere. And you'd visit these houses and there'd be 10 to 14 children per parent. And, you know, I really began to wonder, how is it going to be possible to actually get rid of polio in this kind of environment? It just seemed too difficult. However, it did happen. So even though when I was there was no decrease, ultimately it was successful in eliminating polio from India after a lot of hard work. The last case occurred in January 2011. And there's some really interesting things that came from that success. And one of them was the increased resourcing and always increased attention to detail. So the work that we were doing, trying to improve the quality of the national immunisation days and so on, could be treble or quadruple if you had more people there and really targeted on those areas where there was the most problems. There was much greater attention to that social mobilisation. But also I think some of the really interesting stuff that I wasn't involved in, but I'm proud to know that it was done, is that the polio virus occurred, there's 3 strains, and the second strain, so it's called 1, 2 and 3, and number 2 was the first strain to disappear. It's, you know, if you get rid of polio. So the vaccine for the strain 2, you know, seems to be a bit more effective. And so anyway, we were still giving this 3-dose polio vaccine. And then every time, if the way that the vaccine works, you take the live virus and it colonises in your gut and has to actually cause a little infection in order for you to develop an immunity. But if you've got a whole lot of other viruses in your gut, which you would have if you're living in these places with very little sanitation and hygiene, then they compete with the polio virus, and polio virus may not actually cause an infection, in which case it doesn't leave your immunity. So they initially got rid of the type 2 virus from the vaccine. That was one less competitor. And then ultimately, when they got rid of the next, then they could refine it down even further. And so this was part of the success. And I think it's just fantastic that people did that. But also just want to acknowledge the incredible dedication of the people on the ground. To do this National Immunisation Days, to vaccinate 25 million people over the space of 3 days, required a tremendous cadre of people, predominantly women, getting paid almost nothing, to just do that footwork, go from house to house, mark the houses, give the vaccine, go back where they missed. And it was their dedication, really, sometimes at great risk. A number of them have been murdered in Pakistan. You know, they are really the heroes for the polio campaign. So I'm now just going to talk a little bit about Typhoon Haiyan and Ebola. And I just want to put this up to remind me that I was able to go to these things through a network called GOAN, Global Outbreak and Response Network, which was set up to mobilise people in the case of emergencies. And the 2 people from Curtin University were involved in setting this up, and one of them is still actively involved. One was Aileen Plant, who sadly died a number of years ago, but she was a mentor and a teacher of mine. And the other is Professor John Mackenzie, who's still active on the board and still works for Curtin. So Curtin's a partner for GOAN, and what that means is that Curtin signs up to supporting these kind of responses. So this is Typhoon Haiyan, which occurred in November 2013. I'm sure you remember it well. And it was considered what we call a super typhoon because of 2 things. One is the velocity of the winds. It was the strongest typhoon to ever hit landfall. And secondly, because of its large breadth, I guess, area that it covered, which meant that it carved this path of destruction across the Philippines. And I put this slide up just to remind us that it was not only the size of the typhoon that caused the destruction, but the biggest destruction that occurred was also associated with a massive tidal surge. And this shows the extent of sea level rise around the oceans, and you can see that dark red area next to the Philippines, which exacerbated the tidal surge quite considerably. And of course we know this is due to climate change. One of the features of Typhoon Haiyan was the damage to the health facilities, and a very large proportion of the health facilities were destroyed by the typhoon or damaged. And this, of course, made the response very challenging. So I was asked, I came in very early post-typhoon, about a week after the typhoon hit, and I was based in Manila, and my role was to lead and coordinate the disease surveillance and response activities and try and basically get them set up. And I worked very closely with people who were from WHO and other organisations who were based on the ground. So some of the challenges that we faced was this extensive damage to the health services. And again, not surprisingly, the worst, or sadly actually, the worst affected areas by the typhoon unfortunately happened to be the areas that had the worst health services before. So we're trying to set up a disease surveillance system to look at patterns of disease, only to find that the worst affected areas had very little surveillance beforehand because their health services were not in very good shape. There were challenges of poor communications technology. Most of the mobile phones and the internet was out. And this large number of temporary medical teams, some of whom just came for a month or so, or even less, and then moved on. So the coordination system was very challenging, as was the living conditions on the ground. But not for me. I lived at a very high level of a very smart hotel. So this is some of the team based in Manila. And just to give you a bit of a sense that the number of people working in the Philippines WHO office was multiplied by at least 5 times. And I put a little circle around my head. Okay, probably many of you are here to hear a bit about Ebola. So this is a photo of Ebola. And it's important just to remember a few points about Ebola if we think about the perspective of Ebola control. First of all, you're only infectious with Ebola when you're unwell. So that's really important to think about in terms of control, but also in terms of dealing with people who might have come from Ebola-affected areas. And the sicker you get, the more infectious you get. And that's for 2 reasons. One is you've got more virus in your system. The virus is multiplied, so there's a lot more of it in your blood and body fluids. But secondly, you're more likely to express body fluids. So when you get really sick, you vomit, you have diarrhoea, you're more likely to bleed, you might be coughing and so on. And all of those body fluids will contain lots and lots of virus. And then when you die, the virus can stay in a dead body, alive in a dead body for a reasonable length of time. And so when you die, you've got the most virus in your system because the virus has killed you, and so you're even infectious then. So the control strategies then are to, if you identify cases early when they're not that sick, they're just showing some symptoms such as fever and feeling unwell and fatigued, and isolate them, you can actually stop them from spreading the infection to somebody else. So in terms of control, then you need good treatment centres where people can go, but the key thing is to identify cases, identify their contacts, and make sure that then you follow up those contacts so that if any of them get sick, that they get taken to treatment early. And so your whole point is to minimise the contact that people have with people who are really, really sick. Sounds great in theory, doesn't it? And in fact, it's been very successful right throughout the Ebola-affected areas. It's just been challenging for the last little bit. So this is, I won't speak to this very long, but just to give a bit of a context in terms of Ebola was first, when Ebola was first detected, or when we first knew about it. I'm sure it's likely that there were outbreaks before. This shows a bit of a timeline, and the size of the circle in the top bit shows the size of the cases. They've got Guinea there, greater than 2,000. We now know that there have been many, many more thousands of cases. And this shows a history of the outbreak. So it originally started in Guinea, and then it spread from Guinea to Liberia and then Sierra Leone. And these 3 countries are very, very similar in terms of not necessarily language, but culturally and so on. And there's a lot of movement between them. In fact, people moving to escape civil wars and then moving back and so on. So there continues to be that movement, which explains what happens. But the thing that distinguishes this outbreak from other outbreaks is the fact that quite early on in the epidemic, I can point out Montserrado County that includes the capital Monrovia, that's the dark one there. The virus moved, or people with the virus moved to those places very early on. And that's quite different to previous outbreaks of Ebola in other countries where they were limited to rural areas. So once it moved into places with a lot of people and dense populations, that's when it really became challenging and when we ended up seeing lots and lots of cases. A bit more context in terms of that particular outbreak is to remember that these 3 countries are some of the poorest in the world, and in fact when you look at this, 70,000 Liberians for every doctor in Liberia can get a bit of a sense. While doctors are only a tiny part of the health system, you still get a bit of a sense of the state of the health system there. This is just to remind you, this is taken from a recent report from the WHO, but after there had been no more cases in Liberia, that there had been 10,000 cases in Liberia and up to almost 5,000 deaths. So we're talking huge numbers of people. And this is what you would call an epidemic curve. So what this shows is the number of cases for every week by week. And you can see that it peaked in September, October, and I actually went to Liberia here. And before I went, I thought, you know, I had to go there and I couldn't go earlier because of teaching commitments. And I have to admit that part of me felt a little disappointed that I wasn't going there in the peak time. But what you can also see, it's hard to see really with this scale, but it was flat there. And actually getting rid of Ebola, that last little bit, was the bit that actually required tremendous effort, and I hope to give you a bit of a sense why. So I won't dwell on this too much because I think we're running out of time, but I think it's important just to remember with Liberia, but also Sierra Leone and Guinea, that they've had a series of devastating civil wars. And these civil wars have meant many things, many people being killed, destruction of infrastructure, lack of governance, but also this, you know, the impact on the psychology and so on for people who've experienced that is important to remember. So Liberia has around 4 million people, and we remember that the life expectancy for Nepal is around 68. In Liberia it's only 58, and it's even poorer than Nepal, with its GDP being 224th in the world, so very low. And 80% of the population live below the poverty line, which is a pretty low poverty line. It's about $1.70 per day. I was based in Montserrado County, which included, so it has about a quarter of the population, so that tiny little bit of the map that I showed you has a quarter of Liberia's population and includes Monrovia. And that's my getting to work scene. So I was asked to be the WHO field coordinator for the response for Montserrado County. So that involved leading a team of about 16 people who were working across all the different areas that were required for a response. But our role was really to work with the government and other agencies to support their response. And I had to also coordinate with the CDC, who had quite a lot of people on the ground, and the African Union, who sent hundreds of people to these 3 countries in order to help the response. So that's me with most of my team, and I just want to point out these 4 guys on the end here, they might look to you to be Indian, and they are, and that was a very deliberate strategy to bring in people who'd been involved in polio eradication. So these are surveillance medical officers from polio, and because they bring that kind of experience that could be very, very useful in getting rid of Ebola, that attention to detail, that surveillance, the understanding of what it's actually like to identify cases and do all that contact tracing and the like. And the man standing next to me there, Chikwe Ikwezu, was from Nigeria, and that Nigeria had had experience with Ebola in this current outbreak. And the head of WHO referred to he and I as twins. And as you can see, we look very much alike. But the main thing was that we worked so closely together, and without Chikwe, I would think my job there would have been a much, much harder job. So there were around 5 cases a week when I was there. And over time, not when I first started, but over time the cases were restricted to 1 cluster. So what that means by that is that all of those cases could be traced back to 1 single individual. And that's really good news in terms of trying to eliminate a virus, because that means you can just really focus on that 1 group. It also shows that in spite of the fact this alarm at this huge number of cases, that early on people were wondering, has Ebola become more infectious than before? Turns out not to be the case. Ebola, the virus hasn't changed, The problem was where the virus ended up landing in terms of the population and the people. So these cases, and amongst Montserrato County, predominantly Monrovia, again, the same thing. They were occurring in the most marginalised communities. The contact tracers were sometimes experiencing hostility. There was a lack of trust in government, sometimes not believing in Ebola, as being a disease, maybe something coming from the spirits. So that sort of thing were the challenges that we had to deal with. So I won't dwell on this. This is just to show that transmission from that one case. When she had her infection in December, there were a number of other chains of transmission, but ultimately all of those were gone, except this one. And the key thing about this was the nature of the community where it was occurring, the lack of trust, the lack of cooperation with contact tracers and the like. So the response was really complex. As you can imagine, the global response to this Ebola outbreak was very slow. But once it started, it was huge. So there were people from all over the world, there were NGOs from all over, and trying to get hold of that and coordinate the response, that was both a really positive thing in terms of getting the resources, but also provided quite a challenge in terms of the ability to coordinate all that and make sure that we weren't at cross purposes, that we were working well together and all aiming for the same goal. Many of the staff weren't being paid. They were the government staff, and as you might imagine, if you're pretty low wages anyway, not being paid can make things a whole lot worse. So that impacted on motivation and so on, the issues with data. And this is a very bad photo, but this is taken from the window of a room where I was waiting of the Ministry of Health where I was based, and we were waiting for a meeting, but the meeting was delayed because cars couldn't come in and out because some of the health workers who weren't being paid were letting their views or their presence being felt. And I thought good on them, even though it meant that our meeting was delayed. But unfortunately, that still didn't get them to be paid. So I wasn't working in the treatment, I was working on this public health response, and a critical part was actually, as I said, this identification of cases and making sure that the contact tracing, and there were all sorts of challenges there. The contact tracers were very hard working, or most of them were, but it wasn't necessarily when we first started possible to know, well, who were the ones that were really good and who were the ones that were not so good, because if you have fewer cases but you've really got to nail it, you've got to make sure you get the best. So one of the things that we did was to just really work with their supervisors to identify the best contact tracers and then to really provide them with some additional rewards and incentives so that they'd go the extra mile. Some of the high-risk contacts were lost to follow-up, and this is where our surveillance medical officers really came in because they followed that to the heat. They wouldn't let somebody go until they found out where they were. And that was really important again, because if any of those got sick, you want to make sure that they get detected early so that they don't keep spreading. You might have noticed on that slide where they're showing the chain of transmission that some people were getting infected helping others into taxis. Now, if somebody's got Ebola, they shouldn't be getting into taxis. There's a system where ambulances will call them, and they call up an ambulance, they'll be collected and so on. But remembering in this situation where people weren't necessarily believing they had Ebola, or they might have underneath, but and now they're really, really sick and they've probably got diarrhoea running down their legs and all that sort of stuff. It was something that when you're trying to find out who the contacts were, you don't necessarily think to ask, well, who helped you get into the taxi? And they may not even known. So a couple of good Samaritans ended up with Ebola. And again, they didn't necessarily identify themselves as being at risk either. So it's those kind of things where when you've got hundreds and hundreds of cases, if you can get about 70% of them managed well in their contacts, you will reduce the transmission. But when you've only got 5, 70% of 5 is starting to get lower and lower. So that's where this exact nature of the response becomes so critical. And I mentioned there the community, in the slide, the community resistance, and that was really important as well. And one of the leaders for the response, a Liberian national employed by the government, was actually threatened with a machete one night when he was in an affected area because of some of these community tensions. So infection control was considered by the government as being something that you worry about later, because you've got the Ebola treatment units and all cases should end up going there. But again, as we get fewer and fewer cases and they're getting more in the marginalised communities, they're not necessarily going to the Ebola treatment units. So we found a number of cases when they were really, really sick had gone to either private or government clinics, but non-Ebola treatment units. And these clinics didn't necessarily have either the wherewithal in terms of personal protective equipment or the knowledge to make sure that these cases were isolated and then treated properly with the personal protective equipment. So many, many health workers were put at risk. And one of the things I'm very proud of my involvement when I was there was this, it's a bit hard to conceptualise, but what we call this ring approach. So when a case was identified, going to the areas where and identifying all those clinics and where that had been supposed to had been done already but had been done quite poorly, really training them in triage, how to identify a possible case, how to do the infection control and so on, and what to do if they identify a possible case of Ebola. And that did have quite a significant impact in terms of reducing the exposure of healthcare workers to potential cases. Yeah, I'll just point out that one of the other reasons for the hostility was the high case fatality rate. In January when I was there, about 87% of cases were dying. And the reason why this was, again, was not because the virus had changed, but because often people in most marginalised are not all that healthy to start with, but secondly, they were presenting very, very late to health services. But what this meant to the community was, well, if I go to an Ebola treatment unit, I'm going to die. And there was one child who ended up with Ebola, and the ambulance came to get him, and the contact tracers were there, and there was a demonstration of about 100 people outside his house saying, no, basically don't take him away because, he could die. So that is, again, this sort of perception and this mistrust was one of the big challenges. Community mobilisation was really, really important. And as we get closer, then what we can do, previously there were messages that were targeted across the general community. They were everywhere, billboards everywhere, radio, you name it. And that was really, really effective in terms of most people. But again, if you're trying to reach the hardest to reach groups, that has to be a lot more targeted. And so when I was there, that was something that we did, was to really try and concentrate more on what messages are going to work, who are the best spokespeople, how can we really reach in to these people. So some of the things I learned from that was how, as somebody in that role, I didn't have to be a really fantastic epidemiologist. In fact, that wasn't really all that important. It wasn't rocket science. But in these kind of roles when you're responding and there's lots and lots of people there and there are great minds thinking about the actual response, the coordination and so on of the response really requires those softer kind of leadership skills. And really being able to help to get that coordination and cooperation between a whole lot of people. We were pulled together in a very short time frame, and the teams kept changing all the time as people moved in and moved out. So we had to be able to generate teams that were effective in very short time frames, build lots of relationships. And one of the things that some people commented that I did well, and I think it relates to that, was seen as being neutral in conflict situations. And there was quite a lot of conflict between the different agencies, as you might imagine in such a complex response. But the key thing was, again, this critical role of the community in the response. Those contact tracers, the people who go, or visiting house sometimes twice a day at the end, various houses to elicit any symptoms and so on. The people who were paid very small sums of money to go around listening for rumours about cases and other things. These people were absolutely critical in the response, and the community leadership as well, the mayors and local leaders who played a critical role. So when we think about Ebola, it's easy to think about white people in spacesuits and so on. But to me, the real heroes are these people in the community who day after day after day in their community did this work, sometimes at risk or some physical or social threats, but they still kept doing it. As well as this tremendous resilience of the community. that really came across very strongly. Liberia is a country of amazing people, and you think about their history and so on, just tremendous warmth, get up and go, and resilience. So I'm sure I don't need to tell you what some of the common themes are between those different experiences, but I thought I'd just finish my presentation with highlighting those. So first of all, there's this theme of marginalised populations, and in public health, in any form of public health, including infectious disease control, marginalised populations are often the most affected, and the places where if you want to eliminate a disease, you really have to focus your attention. You need to be able to have considerable amounts of engagement. So infectious diseases is not just about being a brilliant epidemiologist, it requires those same groups of people with same sets of skills that would be required to prevent any disease. And the important need for local people, and they're the pillars, the absolute crux of any response. And finally, that international responses are very complex and very challenging, with a whole lot of changes and new players and politics and the like. And so that leadership and coordination is really important. So I'd just like to finish with the acknowledgement, and I guess particularly to acknowledge Curtin University, who I understand that a number of my colleagues, I know of 3 or 4 who went to one of the affected countries as part of the Goan response. They all had to take leave when they went, so went in effectively their own time, and Curtin has been generous enough to continue to pay my salary while I went to both the Philippines and Liberia, and hopefully to be able to contribute in other ways as well. So effectively, it's Curtin's contribution, not mine. So thank you so much for your attention.